The heart. So the anatomy of the heart, if we look at this imaging here, this is the sternum, and these are the intercostals and costals. So basically this is the interior of the body, and this is the vertebra. So this is the posterior of the body. So it says here that the left atrium is the most posterior part of the heart, and this is true because this is the left atrium and it's considered posterior. The most posterior part of the heart. Enlargement of the left atrium, because it's the most posterior, would, as in mitral stenosis, can lead to compression of the esophagus and causing dysphagia, and or the left cantilaryngeal nerve, which is a branch of the vagus nerve. So this causes hoarseness, and that is Ortner syndrome. So basically, if this left ventricle gets really enlarged, it causes some compression on the structures behind it, so it would cause complications like dysphagia or hoarseness. So for the right ventricle, it is the most anterior part of the heart and most commonly injured in trauma. So left ventricle, okay, so this is the right ventricle. It's the most anterior part, and it makes sense because injuries come to the anterior part of the body, it would be injured. So the left ventricle is about 2/3, and the right ventricle is about 1/3 of the inferior diaphragmatic cardiac surface. So this is the inferior diaphragmatic cardiac surface. This is the diaphragm, and most 2/3, and this is 1/3. So let's say this is 2/3 and this is 1/3. Left ventricle takes 2/3 of the cardiac surface, of the diaphragmatic cardiac surface, and then the right ventricle takes only 1/3. So basically it's due to their size difference. This is the aortic knob. We may need that layer, azygous vein, superior vena cava, descending aorta, and pulmonary artery. So for the pericardium, it consists of 3 layers from the outer to the inner. There is fibrous pericardium, parietal pericardium, and epicardium, which is also the visceral pericardium. So basically, what we have is the fibrous pericardium. It should be fibrous because it needs to be strong and protects the heart and everything. The second one this is the out, this is the inside. So to the inside there is the parietal pericardium, right, and then it comes after is the pericardial space. After it is the epicardium. Epicardium is basically just like the parietal pericardium, but one is called parietal, meaning to the outside, and visceral is close to the viscera. So it feels like these are only one layer that is separated into 2 by the pericardial space. And then below it we can get the coronary vessels, artery and vein, then myocardium over here. This is all like muscle, and then the endocardium, that is the closest part to the viscera of the heart, like the interior most of the heart. So pericardial space lies between parietal and pericardium and epicardium. The pericardium innervated by the phrenic nerve. So the pericardium is just innervated, all of it is innervated by the phrenic nerve. Pericarditis can cause referred pain to the neck, arms, and one or both shoulders, often left, because the dermatomes, as far as I remember, are connected with each other, and it is the pericardium is innervated by the phrenic nerve, and the phrenic nerve has some other dermatomes all over some other places in the body. So I think that's how it can transmit the pain, or refer to pain happens to the arms or both shoulders. For the coronary blood supply, we have 3 main coronary arteries, left anterior descending, and then PDA, that is the posterior descending artery, and the right coronary artery. So for the LAD, it's an AC branches supply the interior 2/3 of the interventricular septum, and the anterolateral papillary muscle and anterior surface of the left ventricle. So basically the mitral valve has 2 papillary muscles. One is, this is based on my own knowledge, so Mitral valve has two papillary muscle. One is the anterior lateral, and the one is posterior medial. So for the anterolateral, the first one, this is the one, anterolateral papillary muscle, it is innervated by the left anterior descending. This artery is most commonly occluded. So it's the, if we have an inclusion in the coronary artery, the first thing that comes to the mind should be the left anterior descending. And it is this one. So it makes sense because this is the left ventricle, this is the right ventricle, so it covers the first 2/3, like anterior 2/3 of the interventricular septum. So and for the back, then we have the PDA, and that is the posterior descending artery, and it makes sense as well because it's just going midway between the posterior surface of the right ventricle and the left ventricle, so it makes sense if it supplies the posterior third of the interventricular septum as well. And also it provides the posterior medial papillary muscle, so it's just the other type or the other papillary muscle that we have, that is the posterior medial, is supplied by the PDA, the posterior descending artery. So just recap, it's posterior 1/3 of the interventricular septum and posterior 2/3 of the walls of the ventricle. So this is just the wall of the ventricle, and it's big, and posterior medial papillary muscle. While for the right coronary artery, it supplies the AV node and SA node, and infract may cause nodal dysfunction. So leading nodal dysfunction, of course, this messes up the electricity of the heart, so it may cause bradycardia or heart block. So what we have here is that this is the right coronary artery, and we can tell that this is the right atrium, so it's very close to the SA node and AV node, and this is just the interior of the heart. So the SA node is here, the AV node is here, so basically the SA node, for example, is here, not for example, this is where it should lie, and this is the AV node. So this is SA node, this is AV node, and we can see they are orange, so they are supplied by the right coronary artery. So if there is a blockage in the right coronary artery, then that messes up the SA node and the AV node. For the right acute marginal artery, it supplies the right ventricle. So this is the acute marginal artery, and it just comes off the right coronary artery, and it supplies the right ventricle. So this is the right ventricle, and it goes posteriorly as well. So for the dominance is basically it all depends. Let me clear up this mess a little bit. So the dominance is just basically depends on the PDA, this artery. Where does it come from? If it comes from the right coronary artery, because we know this orange thing is the right coronary artery. So if it comes from right coronary artery, and that happens in most of the people, like most of the people have the PDA coming off the right coronary artery. So this is considered, because this is right side and this is left side, okay? You can see here left side, this is right side, and this is right side. So if it's coming from the right coronary artery, which lies on the right side, that means it's right dominance. So right dominant circulation, that is the most common. PDA coming from the RCA. While if this PDA does not come from the RCA, and instead it just comes from the left circumflex artery. This green artery is the left circumflex artery. So if it comes from here, not from the right coronary artery, this is the left side. So this is considered a left dominant circulation, and where the PDA comes off the left circumflex artery. In some people, this PDA comes from both arteries. So let me clear up this. So some people, they have this PDA coming from the right coronary artery and also coming off the same left circumflex artery. So basically it comes from both. They both contribute to the formation of the PDA. This is considered codominant circulation, where PDA arises from both left circumflex artery and right coronary artery. So the coronary blood flow to the left ventricle and interventricular septum peaks in early diastole. So in early diastole, the ventricle is kind of not filled yet, so it doesn't have a lot of tension on the walls due to the presence of a blood. So the pressure inside is low, and also there is no wall tension of the ventricle. So this is where we get to the peak of the coronary blood flow. The coronary arteries get just too comfortable because there is nothing compressing them, because already the left ventricle is kind of empty. While the coronary sinus runs in the left AV groove and drains into the right atrium. So basically, this is the AV groove. It's just the atrioventricular groove, and it takes the blood from all of the veins of the coronary veins, all of the blood from the coronary veins, and it drains into the coronary sinus. And it contains, of course, this is something that needs to be known, it's really important, is that the coronary sinus is the most deoxygenated blood in the whole body, because the heart muscle takes up to 70% of the oxygen that it gets, so uses really a big amount of oxygen. So the return of its blood, like the venous blood of the myocardium, it just contains too low oxygen. So that's considered like the lowest level of oxygen in the body. So it's considered the most deoxygenated part of the body. That is the blood in the coronary sinus. Here, just to let us understand the places, the SI node is located by the upper anterior right atrium. This is the right atrium, of course. While the AV node at the opening of the superior vena cava. So this is superior vena cava. So it's at the opening of the superior vena cava. While the AV node is at the endocardial surface of the right atrium, near the insertion of the septal leaflet of the tricuspid valve and the orifice of the coronary sinus. Okay, makes sense. There you go. And near the orifice of the coronary sinus, it opens close here. So the location of the AV node can also be described as the interarterial septum near the opening of the coronary sinus. The heart extracts up to 70% of oxygen from blood. So